Good morning, students. Today we will discuss a new topic, that is neonatal jaundice, jaundice in newborn. Obstetrics contains two parts, obstetrics and neonatology. Questions should be asked from neonatology also. Child care actually means neonatology or the newborn infants. There are some conditions we should know about newborns. We can expect some questions from this part also, that is neonatology. So we should learn some basic idea about different common conditions seen during a newborn period. This include topics like neonatal jaundice, asphyxia neonatorum, ophthalmia neonatorum, UPCAR score, breastfeeding, immunization, etc. Today we are going to discuss about one topic, that is neonatal jaundice, jaundice in newborn. Usually it is a short answer question. So questions will be like that. Give a short description about neonatal jaundice and give the indication of podophyllum in neonatal jaundice, like that. So we should know about this condition, clinical presentation, diagnosis, complication, and the therapeutics also. What are the indicated medicines with their indication? All of you know what is jaundice. It is the yellowish discoloration of skin and mucous membrane due to increased level of bilirubin in the blood. The usual etiology of jaundice is hepatitis in adult, viral and non-viral hepatitis. So in adult, the jaundice is mainly due to viral hepatitis and alcoholic hepatitis, but it is not the case in newborn child. In newborn child, if the child presents with jaundice, it is not mainly due to hepatitis. There are many various reasons for the neonatal jaundice. Let us have a discussion about this neonatal jaundice. Majority of child born with a little jaundice. It is commonly present. It is not an abnormal condition, but sometimes the bilirubin level may increase and it produces some problems. So in neonates or newborn, we can see two types of jaundice, physiological jaundice and pathological jaundice. We have to differentiate between physiological jaundice and pathological jaundice. Then only we can manage this condition. Physiological jaundice is more common and pathological jaundice is less common. Although the name is physiological jaundice itself sometimes causes complication and cause some severe defect in newborn. So we cannot neglect physiological jaundice also. What are the difference between physiological jaundice and pathological jaundice? Physiological jaundice appear usually after 24 hours of birth. If a newborn born with jaundice, that is not a physiological jaundice, that is a pathological jaundice. So pathological jaundice usually appear within first day of birth or within the first 24 hours. That is the first difference. Then in physiological jaundice, level of bilirubin usually up to 12 milligram percentage and lasts for 2 weeks only. But in pathological jaundice, there is a more increased level of bilirubin with a rate of more than 5 milligram per day, and it lasts more than 2 weeks. So physiological jaundice lasts only for 2 weeks. Sometimes it may last some more days also, but pathological jaundice lasts for more than 2 weeks. Physiological jaundice is usually unconjugated hyperbilirubinemia. That is, here unconjugated bilirubin level increases. But in pathological jaundice, we can see both increased level of conjugated and unconjugated bilirubin. And the main cause of physiological jaundice is immature conjugation, or the liver of this newborn is not mature for conjugation. That is why there is an increased level of unconjugated bilirubin blood that will cause us jaundice in newborn. That is the main cause. Again, the increased level of neonatal RBC. Neonatal RBC undergo destruction at an increased level, that will also leads to increased formation of bilirubin. But pathological jaundice is entirely different. The causes of pathological jaundice is entirely different. The main causes are RH and ABO incompatibility, the blood group incompatibility, intrauterine infection if hepatitis occurs during uterine life. So the newborn born with the jaundice. In this case, jaundice will present first day itself. But in physiological jaundice, it will appear only after 24 hours. So in short, physiological jaundice is unconjugated hyperbilirubinemia in newborn due to immature conjugation and increased destruction of RBC of newborn. It starts second day onwards, disappears within 2 weeks, and peak level reaches 3 to 4 days. And level of bilirubin may reach up to 12 milligram percentage. In some infants and in preterms, this may also reach to 14 or 18 milligram percentage. That is called exaggerated hyperbilirubinemia or exaggerated neonatal jaundice. So we have to assess the level of bilirubin in newborn without checking for blood or without doing a laboratory investigation. We can assume the level of bilirubin in blood by looking the patient or by the physical examination of the newborn. How is it possible? We can examine the newborn wherever this jaundice or yellowishness is present. According to that, or according to the location or the presence of jaundice in different parts of the body, we can assume the level of bilirubin in blood. This is the chart. If yellowishness or icterus present only in face, then serum bilirubin will be up to 5 milligram percentage. If the child have a jaundice on face and upper trunk or face and chest, then bilirubin level will be 8 milligram percentage. If the yellowish discoloration or jaundice is present up to lower trunk also, that is face, chest and abdomen, then it will be 12 milligram percentage. Up to this level, it may not causes any complications or it may not causes any problems. So we can easily manage up to this level, 12 milligram percentage. Or if the child is having yellowishness on face, chest and abdomen, the bilirubin level will be up to 12 milligram percentage and can be easily managed. But if the yellowishness again extends up to thigh, face, chest, abdomen and thigh, the bilirubin level will be 15 milligram percentage. And if when it reaches the lower legs or face, chest, abdomen, thigh and lower leg, all is icterus, show icterus or yellowishness, then bilirubin level will be 12 milligram percentage. And if the palms and soles of the newborn infant show icterus or yellowish discoloration, then bilirubin level will be more than 20 milligram percentage. This is a very dangerous level. Above 50 milligram percentage is also dangerous, and if it reaches above 20 milligram percentage, it may cause serious complications like ancophyllopathy. So even though the name is physiological jaundice, when the level of bilirubin reaches more than 20 milligram percentage, that will result in serious complication known as bilirubin induced ancophyllopathy. This is the main complication of physiological jaundice, and we can see 4 stages in bilirubin ancophyllopathy. In stage 1, the child shows poor feeding, poor reflexes with a high pitched cry. So a jaundiced baby with yellowish discoloration on lower extremities, arms and soles, showing the signs and symptoms of poor feeding and high pitched cry, we should suspect a bilirubin encephalopathy. In stage 2, seizure starts with opisthotonus and fever. In stage 3, spasticity is decreased. Stage 4 is the late sequelae or late complication, including cerebral palsy and mental retardation. Our duty is to identify the signs and symptoms of early signs and symptoms of exaggerated hyperbilirubinemia, which leads to this encephalopathy, and refer the child as early as possible. We cannot manage this condition, bilirubin encephalopathy. So our aim is to prevent this bilirubin encephalopathy, or our medicines will prevent this bilirubin encephalopathy by regulating the bilirubin level within normal limits. So identify the signs and symptoms of bilirubin encephalopathy in 4 stages, stage 1 to stage 4, and if it is not controlled properly, that will result in sequelae complications like cerebral palsy and mental retardation. What is the management of hyperbilirubinemia in newborn or neonatal jaundice? The general management of neonatal jaundice is phototherapy. All you know about this phototherapy? Phototherapy can be done in hospital, institutional phototherapy, using special equipment. Here the most effective wavelength of light is blue lights. Baby's eyes should be covered securely during phototherapy, and proper breastfeeding is done during phototherapy. We can advocate phototherapy in home also. The child is advised to exposed sunlight during morning hours and evening hours for a few minutes. Sometimes it is enough to manage this hyperbilirubinemia. If the level is not that much high, if the level of bilirubin is less than 12 milligram percentage or so, we can advise phototherapy in home also along with our medicine. What are the main indicated medicines for neonatal jaundice? We can very effectively manage neonatal jaundice. In modern system, there is no effective medicine in neonatal jaundice, but with our medicine, indicated medicine, we can very quickly and very effectively control neonatal jaundice. Even when the bilirubin level reaches up to 15 milligram percentage, within 2 or 3 days, it will become normal with our medicine. The most commonly prescribed medicine is chamomilla. That too in 1 potency, a single dose will give a very quick and fast relief for this neonatal jaundice. Other medicines are Maxol, natrum sulph, and podophyllum. These are the commonly prescribed medicine in clinical practice. There are so other medicines in Media and repertory. So questions will be asked about the indications of other medicines also. So I am telling about the commonly prescribed medicine. Sometimes we have to give medicine to mother also in case of neonatal jaundice, and the indicated medicines are acid phos, Merxol, Cilicia, Calcarea phos, and Gellegia officinalis. These are some medicines we usually given to mother to improve the quantity and quality of breast milk. So for every conditions of a newborn infant, sometimes we have to give medicines to mother also to improve the quantity and quality of breast milk. Thank you.